This is a stamp honoring Christian Doppler, for whom the Doppler effect is named. I suppose a little bit of consolation for him only getting this stamp was the fact that he had a stamp with a small physics tutorial at the bottom that you could see those two diagrams showing the Doppler effect diagrammatically. But when it comes to Doppler, to borrow the tagline from the folks at overstock.com, it's really all about the O. And actually, it's not the O I'm talking about, it's the angle. And that's illustrated in this image of a color Doppler sonogram of a carotid artery. It may look that we're nicely below the magic angle of 60 degrees, here set at 42 degrees, but if you take a close look at the color Doppler image on top, you can see that the angle correction doesn't match the flow in the vessel as it should. It should really be set like this. Why is this so important? As we'll see as we go through the abdomen, some of the diagnoses you're going to be making within the abdominal vessels depend on accurate velocity measurements. To illustrate the importance of this, we go back to the Doppler equation, which you see at the top. If you rearrange the terms, you show how the machine is calculating the velocity within the vessel. C, the velocity of sound, is known. The Doppler shift is measured by the machine. F is the incident frequency. So the only variable left is that angle theta, the angle correction, or more correctly in this case, the cosine of that angle. The machine has no way of knowing what that is. You tell it what it is by setting the Doppler angle correction cursor. Let's look at an actual example here of a vessel with a true flow velocity of 100 centimeters per second and an angle of inclination of 60 degrees. All the other values are either constants or have been measured. In this case, the shift is 3,250 hertz. So if you're diligent and you set the angle correction properly, as I'm illustrating here, the measured velocity will be very close to the actual velocity of 100 centimeters per second. But what if you make a mistake and you're off by only 10 degrees, as is shown here? You've set a correction of 50 instead of 60. Remember, the machine doesn't know that it should be 60. You've told it. The calculated velocity in that case, as shown by the machine, will be 78 centimeters per second. That's a big difference. So angle correction is absolutely critical. If you don't do it properly, you will make errors in velocity measurements, and that can translate to errors in diagnosis. Note that that's not the same as a true 50-degree Doppler angle, as is shown here. If the angle is really 50 degrees, that's where you should set your cursor. The Doppler angle correction cursor should therefore be set parallel to the vessel, or more correctly, parallel to the flow stream in the vessel, which usually is parallel to the vessel wall. So with that introductory technical point, let's do a quick tour through the abdomen. I'm going to cover the liver vasculature, followed by the renal vessels, a little bit on mesenteric arteries, and close with the IVC. Let's start off with the hepatic vasculature. The most prominent feature of the liver vasculature is the portal venous system, which we look at on pretty much every abdominal sonogram. The portal venous system accounts for about 70 to 75% of flow to the normal liver. Flow is usually monophasic, but it can be pulsatile in patients with right-sided cardiac dysfunction, right heart failure, tricuspid regurgitation, and in fact in some young individuals. And the normal velocity is extremely variable. This color Doppler sonogram shows a normal main portal vein with monophasic flow, in this case a velocity measured at the peak, although the use of the term peak here is a little bit different from the way it's used in arterial flow because it's not pulsatile, but in this case about 29 centimeters per second. As I said, the velocity varies widely. And as I also just mentioned, it can be quite pulsatile, as in this case of a patient with right-sided cardiac dysfunction. Portal hypertension, which we are often asked to look at in our patients, may be classified as intrahepatic, either pre or post sinusoidal, or extrahepatic, pre or post hepatic. It's defined as a portal vein to hepatic vein or IVC gradient of greater than or equal to 12 millimeters of mercury. The signs include dilation of the portal veins, SMV and splenic vein, and detection of collaterals with hepatofugal flow. And these collaterals are myriad, including the coronary vein, the short gastric veins, the umbilical vein, or spontaneous splenorenal shunts. And the most commonly seen or looked for sign, reversal of flow in the portal vein. Dilation of the portal vein is really not a very sensitive sign of portal hypertension, but when the portal vein is as large as we see here, almost 2.2 centimeters, that's a pretty good indication that flow within the portal venous system is abnormal. Here we have an example of reversal of flow in the main portal vein, as is shown by the blue color within the vein, showing flow away from the transducer and hence out of the liver. And here is the same patient shown on a spectral Doppler tracing with reversal of flow. At first glance, this sonogram looks pretty normal. We see the main hepatic vein with flow into the liver, and we see it here in the clip with a lot of hepatic arterial flow around it. And in fact, that could be a little bit of a clue because that's a common finding in cirrhotic patients. But if you follow flow through the liver and look diligently for the collaterals I mentioned, you'll find flow directed from the left hepatic vein along, in this case, a patent recanalized periumbilical collateral vessel. And this vessel can be followed along the anterior abdominal wall, indicating that there is portal venous hypertension. Often we see varices near the splenic hilum. On grayscale, the spleen here is shown to be enlarged, but there are a number of sonolucent structures near the hilum which, on color Doppler imaging, light up, and these are varices in a patient with portal venous hypertension. Portal vein thrombosis is another diagnosis we get asked to look for quite frequently. But it's important to note that it may be very difficult or even impossible to distinguish very slow flow from actual thrombosis. Grayscale imaging is as important as Doppler interrogation because non-obstructive portal venous thrombus can be very difficult to see with color Doppler, where the color signal overwrites the thrombus. It's also important when you see thrombus in the portal venous system to look for flow in tumor thrombus in the setting of hepatocellular carcinoma. And I'll say more about that, how to detect that later. Here's a case of portal vein thrombus. In this case, there's no doubt that all these echoes within the portal vein are abnormal and indicate true thrombosis. And here's another case, in this case a clip, a lot of arterial flow, but no flow in the main portal vein, which is filled with low to medium level echoes indicating thrombus. In some cases, with long-standing thrombus, you can get so-called recanalization of the portal vein, that is development of multiple collaterals. And in some cases, those collaterals can, as in this case, simulate a patent portal vein on color or spectral Doppler imaging. And it's important not to fall into this trap and call this a patent portal vein. Usually the collaterals are smaller, more tortuous than the main portal vein, and it's important to follow the portal venous system from outside the liver, that is the splenoportal confluence, into the liver, and that usually makes it obvious. Portal vein thrombosis, as I just said, can also be related to hepatocellular carcinoma, as in this case. Especially in a cirrhotic, if you see portal vein thrombus, you need to look diligently at the hepatic parenchyma for the associated HCC. In some cases, the portal vein thrombus can be biopsied if there is no other suitable biopsy target, as I'm showing here. There are usually three major hepatic veins, right, middle, and left, but variations in accessory vessels are quite common. The waveforms are normally triphasic,